name is Melissa Allison Crosby, and I'm presenting my senior presentation here today. It's on ultrasound-guided peripheral IV insertion training for nurses in the emergency room, and I'd like to thank all y'all being here today. These are my co-workers. We have Daryl, who is a floor nurse. We have Tricia, who is our emergency room director. We have Megan, who's a floor nurse, and we have Wynn, who is one of our techs and our coder here in the ER. So without further ado, I would like to present my senior project presentation for you. So like I said, I did it on ultrasound-guided peripheral IV insertion training for nurses in the emergency room. The reason I chose this topic is because IV access is an important component to the patient's care in the ER. Failure to obtain IV access can cause difficulties with the ER staff and the patient. One option for IV access is the use of ultrasound to help guide insertion. Ultrasound-guided peripheral IV insertion is currently used in our ER, however, it is done by the emergency department physician. With proper training, nurses can learn to perform this task, which benefits everyone involved. And this presentation is mainly on the importance of the training, not necessarily the actual training itself. So what is ultrasound-guided peripheral IV insertion, and why do nurses need it? Well, you have an IV, you have an ultrasound, you put those two together, and voila, you get an ultrasound IV insertion. Ultrasound-guided peripheral IV insertion is used when traditional methods of IV insertion have failed, or when the patient is known to be a hard stick. We know we've all had those hard stick patients. What are some common reasons for the patient to be considered a hard stick? Diabetes, cancer or history of chemotherapy, cardiovascular disease, and I apologize for these being so small, end-stage renal disease, COPD, mastectomy, they have had a history of a mastectomy, either side or both sides, contractures, the pediatric population, hematomas, if their arms are covered in hematomas, and we get a lot of older people who have fallen who have hematomas on their arms, people who are considered morbidly obese, history or current drug abuse, patients with dark pigmentation to their skin, hypotensive patients or dehydration status, and history of multiple venous cannulations. All those patients are considered hard sticks. So, just how common are these patients? Anybody want to take a guess? 23% of the patients have things that are difficult to cannulate. So putting this in perspective, let's say we see an average of 70 patients here in our ER a day. If every patient needed an IV, 23% of 70 patients would be 16 patients each day that would be hard to stick. That's a lot of patients. That's a lot of missed opportunities there. So 23%. Now, why do patients need peripheral IVs? Well, for fluid administration or medication administration, for the administration of blood products, for trauma and or emergency situations, diagnostic radiologic testing with contrast. Those are all reasons that a patient would need an IV here in the ER. Reasons why nurses are unable to obtain peripheral IVs? Well, unfortunately, not every patient comes in with veins like the patient on the left. We salivate over those patients when we see them. We're like, yay! Most of them come in like the patient on the right. So, lack of visual or palpable venous anatomy, dehydration, morbid obesity, history of chemotherapy, and drug abuse. Those are common ones. When nurses have multiple failed IV attempts on a patient, this causes a countless number of problems. It can cause physical and emotional strain on the nurse. It passes the responsibility of vascular access to the emergency department physician, which affects patient wait times, delays treatment and diagnosis, and causes crowded waiting rooms. It also causes physical and emotional stress on the patient. It increases the patient's anxiety, because they have to be stuck multiple times, and increases the pain, of course, from those multiple cannulation attempts. It also increased the patient's cost because of wasted medical supplies, and it also may lengthen the patient's emergency department stay having to wait on vascular access. It also exposes the patient to the need for a central line to include triple lumens, PICC lines, implanted ports, or intraosseous accesses. So, how does ultrasound-guided peripheral IV insertion benefit the nurse? It can increase patient satisfaction compared to the traditional technique. We all know that we like high patient satisfaction scores. Research states that it's twice as fast as the traditional technique. And some people may go, what? But you can't argue with the research. And it significantly decreases the number of skin punctures that a patient would receive. It also improves patient health care outcomes, and it improves the nursing practice. So how does ultrasound-guided peripheral IV insertion benefit the patient? It decreases the need for central venous catheter placement in 85% of the difficult IV access patients. And if we go back to our example of having 70 patients a day and 16 of them being hard sticks, 85% of that 16 patients would equal 14 patients that would avoid having CVC placement if we were able to place IVs by ultrasound. Patients also have fewer immediate complications. They receive faster vascular access, and they have reduced costs because the nurse does not have to use multiple items for multiple attempts. So, it prevents the requirement of the triple lumen, the interosseous, the implanted port, and of course, the PICC line. So, what does the training consist of? It's a 3-hour training course taught by the emergency department physician, Dr. Michael Ferguson. It includes introduction to the ultrasound machine, to include the probes, the different types of probes, and how to use the depth, the auto gain, the color, and all the little secrets to making the picture better on the ultrasound machine. It includes a review of the vascular anatomy of the arm, so that you know which vein and which artery you're looking at when you're looking at the ultrasound machine. And it includes using the probe and ultrasound to differentiate between veins and arteries. Remember, when you depress a vessel, the vein will stay depressed and the arteries will pulsate. However, if you are unsure, if you'll look at the picture on the right, the top is an artery, the bottom is a vein. But if you add color to it, you can see it. The red is pulsating is the artery, of course, and the blue is the vein. And these are the same pictures, just one's in color. So the training will help differentiate between the two. It also includes practicing the actual insertion of the peripheral IV using the ultrasound for guidance, learning how to put it all together. Proper site preparation, because you don't want to use too much gel when you're starting IVs because it makes a mess. Proper catheter size, and the actual threading of the catheter. And that picture on the right is the actual catheter that we use. It's an intracranial catheter, safety catheter. It's a 2.5-inch 18 gauge that we use in the upper arms. And that's the picture on the bottom left is the actual catheter. However, those are used in the upper arms. The regular IV catheters can be used in the lower arms. So the expected outcomes of this training would be that it decreases pain for the patient, it decreases costs for the patient, it decreases the workload of the nurse and the nursing staff, and especially the emergency department physician. It decreases the need for multiple nurse involvement, and it decreases the need for central venous catheter placement. Other expected outcomes is that it increases patient satisfaction, it increases patient flow, and it increases the nurse's skill level. And of course, it improves patient outcomes. So in conclusion, and I conclude my senior project with this, developing a training program for emergency nurses in ultrasound-guided peripheral IV insertion is easy, safe, and feasible. Ultrasound-guided peripheral IVs can be successfully placed by emergency department nurses. The patient, the emergency department physician, the nurse, and the emergency department itself would benefit greatly from this training program. Any questions? I appreciate y'all all being here.